In this lecture, we will talk about medications used for pulmonary conditions. These are your objectives for this presentation. We will look at the medications, brief pharmacology. We'll classify the drugs. We'll learn about the side effects and make a mind map to simplify the classifications. Cough and cold are fairly common conditions. And a lot of these medications that are used for these conditions are obviously for respiratory reasons. These are available over the counter for the most part with some restrictions. So remedies for cough and cold can be classified as antitussives, decongestants, antihistamines, mucolytics, and expectorants, and oxygen therapy. Now, antitussives are medications that suppress cough and cold. A full list for this is available on table 26.1 on Secone page 400, and you can refer to that. As far as decongestants are concerned, decongestants are on table 26.2 of Secone page 401, and decongestants are drugs that reduce congestion in the respiratory tract, especially in the upper respiratory tract. Antihistamines are drugs that reduce allergies or manage allergies, and then mucolytics and expectorants help in better flow of sputum, which is hard to otherwise get rid of. And oxygen is a drug, as you should know by now. So those are things that we will talk about in this. So looking at antitussives, as I explained, these are cough suppressants, and there are a few different categories of cough suppressants. Drugs which are opioids, drugs which are antihistamines, and there is a drug called dextromethorphan, which is one of the best known cough suppressants that are used. The most common opioids that are used as antitussives are codeine, hydrocodone, and hydromorphone. The side effects of any of these drugs is same as any other opioid category because opioids affect the opioid receptors in the brain. And in doing so, it induces drowsiness, sleep, oversedation. It also causes tolerance, which means over time more and more of these drugs are needed, and eventually dependence, which means without these, the body cannot function. Now, antihistamines are used to suppress histamine activity in the body, which is related to allergies. The most common anti-allergic medication which is used as an antitussive is diphenhydramine, which is Benadryl. Now, Benadryl is a non-selective first-generation antihistamine with significant sedating properties and anticholinergic properties. So how does it work? It works on the medulla by increasing the threshold for cough. Now, these antihistamines cross the blood-brain barrier, and therefore they cause drowsiness, respiratory depression, blurry vision, urinary retention because of the anticholinergic effects, which is also going to cause dry mouth. So anticholinergic features urinary retention and dry mouth. Now, there are newer antihistamines in the market, and these antihistamines uh, have the property of less sedation, less drowsiness. Regardless, it still is important to remember that it may cause sedation and drowsiness, just not to the extent that the first generations used to. Examples of these antihistamines are Zyrtec, cetirizine, loratadine, which is Claritin, desloratadine, which is Clarinex, and Allegra, which is fexofenadine. So these are some of the newer agents. Of course, there is a more comprehensive list on the SICON text table 26.3 for drug names only. That's all I need you to know. Dextromethorphan is a highly effective cough suppressant. It is the active ingredient in most cough suppressants. So it is used in suppressing non-productive cough. That is cough that does not have associated expectoration of sputum with it. Now, normal non-productive cough is caused by irritation of the respiratory tract mucosa via chemical or mechanical irritants. Dextromethorphan can very effectively suppress these kinds of coughs. The kinetics of dextromethorphan is that it is very well absorbed and can have a time to action of 15 to 30 minutes after oral ingestion. The drug is delivered in the form of a liquid in a suspension. That is what cough syrups are. The maximum duration of effect of this drug lasts up to 5 to 6 hours, and in some people it can be less, but 5 to 6 hours we can find that drug to be effective. It should not be used repeatedly within 6 hours of administration. The adverse effects of dextromethorphan are mild. It is uncommon to have significant side effects. However, the ones that are seen include nausea, vomiting, uh, stomach discomfort, and constipation. Now, remember, these are non-specific signs and symptoms. Could be from various other reasons, not just dextromethorphan. So it may be a little hard to pinpoint it to be related to dextromethorphan. Before we talk about decongestants, just want to clarify what congestion is. When we use the word decongestant, we are really talking about nasal congestion. Nasal congestion is blockage of the nasal passages, usually due to membranes lining the nose and the nasal mucosa, which becomes swollen from blood vessels which are inflamed within it. So nasal decongestants are drugs that target the discomfort directly by reducing the amount of blood supply that comes to the nasal mucosa. Therefore, we use drugs in this particular category which are vasoconstrictors. So by its effect of being a vasoconstrictor, we target drugs of the alpha 1 agonist category. If you remember, alpha 1 stimulation causes vasoconstriction. So the drugs that belong to this category are ephedrine, pseudoephedrine, oxymetazoline, and phenylephrine. All of these are fairly common drugs in use. So what are the adverse effects of these drugs? They can, by nature of being alpha 1 agonists, they can excite the cardiovascular system, especially when the dosages are high or if it's being abused by being taken too much of it. So it is important to remember that it should not be abused. The other thing is that these decongestants, these categories of drugs, uh, can be used for illicit activities. If you remember Walter White from the hit TV serial Breaking Bad, these drugs can serve as the starting base for developing amphetamines, which is what was shown in that TV serial. Many pulmonary disorders lead to a hypersecretory state. The mucociliary elevator may also be damaged due to the effects of the underlying disease. In such cases, significant amount of mucus that will be produced may end up being retained. Over time, mucus will get thick and sludgy, and the patient will have difficulty in coughing it up due to weakness of muscles and inadequate hydration, which makes the sputum sticky, among others. Drugs are available to reduce the thickness of the mucus. These drugs are called mucolytics. At least three different options of mucolytics are hypertonic saline, N-acetylcysteine, which is known as mucomist, and Dornase alpha. Despite the fact that they are all mucolytics, they have different mechanism of actions. So let's take a brief look at each one. N-acetylcysteine or mucomist is the ubiquitous mucolytic that is used in clinical practice. The drug, it's a liquid which works by breaking up the disulfide bonds between the glycoproteins of mucus. This allows the mucus to flow freely. This drug works well with the mucus produced in diseases such as COPD, bronchiectasis, and similar obstructive defects. It does not work well, however, for the significant secretions of cystic fibrosis. Uh, for that reason, a different drug is available. The adverse reaction of mucomist is that it triggers a reflex bronchoconstriction that may be adverse even because it's common to use mucomist in these disorders that produce mucus but also have bronchoconstriction that can be exacerbated by mucomist. Therefore, this drug is always given under cover of a bronchodilator that opens up the airways and allows the mucus to flow freely that is liquefied by this drug. Hypertonic saline has been found to be a useful mucolytic for milder cases of cystic fibrosis. The serendipitous discovery of this feature was by surfers who also had underlying cystic fibrosis who found themselves able to expectorate mucus better after uh, sessions of surfing where they were inhaling the surf from the waves of the sea. And that's how it was found to be of use in that condition. The third mucolytic that is available in US pharmacopoeia is Dornase alpha. Dornase alpha is sold under the trade name of Pulmozyme. It is a highly purified solution of recombinant human deoxyribonuclease 1. The enzyme cleaves the DNA in thick secretions, specifically in cystic fibrosis. It is the only product in the market for this particular application in cystic fibrosis. So Dornase alpha is prescribed to cystic fibrosis patients only. Now, expectorants are drugs that facilitate production and ejection of mucus when there is an underlying dry cough. There is the only one product in the US market that can do this, and that is guaifenesin. The adverse effect of guaifenesin is usually GI upset especially if it is used too much. So it is a relatively safe drug to take. Let's now look for drug therapy in obstructive disorders. The hallmark of obstructive disorders of the airways is obstruction. And this obstruction is created usually by a combination of bronchoconstriction and excessive mucus. Bronchoconstriction is present primarily in conditions such as asthma, which is a reactive airway disease, but bronchoconstriction can also be found in non-reactive airway disease such as COPD. In either case, drugs that allow for opening up of the airway and reversing bronchoconstriction is called bronchodilator drugs. The goal of bronchodilator therapy is one, to allow quick relief. That means if a person is gasping for breath because of narrowed airways, it quickly opens it up. And secondly, in reactive airway disease, it helps in controlling the drugs or the bronchoconstriction over a longer period of time by preventing the mechanisms that lead to bronchoconstriction. Quick relief of bronchoconstriction is achieved by two categories of drugs. One are anticholinergics, and the second one is short-acting beta-1 adrenergic agonists. Anticholinergic drugs bronchodilate via blocking the muscarinic cholinergic receptors. These drugs, the best ones known in the market, are ipratropium bromide or Atrovent and tiotropium bromide, which is called Spiriva. These are delivered as inhalers, and they are metered dose inhalers. That means each time the inhaler is depressed, it leads to the release of a very specific amount of drug that per depression. The adverse effect of anticholinergic drugs is seen due to systemic absorption, similar to atropine-induced symptoms. These drugs are primarily delivered in the airways, but some of it may be swallowed and eventually absorbed into the bloodstream from the gut, and that's how it gets into systemic circulation. It leads to dry mouth, constipation, urinary retention, blurred vision, and confusion. Otherwise, without systemic absorption, these drugs are relatively safe to use. Short-acting beta-2 adrenergic agonists are also very effective, rapid relievers of bronchoconstriction. The drugs in this category are albuterol and salbutamol, which are pretty similar drugs sold under the trade name of Ventolin. Then there is salmeterol, which is sold as Serivent, and formoterol, which is Foradil. These drugs can be delivered in multiple ways. It can be oral, subcutaneous, inhalation, and so on. Now, the inhaled drug delivery of albuterol is perhaps the best, or not the best, but the most common way of delivering them. These are delivered in the inhalation route using nebulizers and meter dose inhalers and Spacehalers. The uh, devices, the nebulizers, MDIs, and Spacehalers are discussed in the equipment lecture provided separately. The adverse effects of short-acting beta-2 adrenergic agonists are tolerance, which means that you need over time more and more drug dosage to achieve the same effect. It may induce cardiac abnormality if the drug is systemically absorbed and reaches the bloodstream. Long-term use of bronchodilators is very notable for development of a very fine tremor. The tremors are very visible in the hands but can be in other body parts. These tremors will not go away because the patient will continue to need these drugs, and these tremors are secondary side effects for that. You can refer to the beta blockers section for additional details in cardiopulmonary or especially in cardiac pharmacology separately. Now, long-term control are drugs that are used to suppress or control the symptoms and development of an asthmatic bronchoconstriction. The first group of drugs that is important in this category are the xanthine derivatives. The drugs are specifically theophylline, aminophylline, and theobromine. They're delivered either orally or sometimes rectally. These drugs can and do develop significant adverse effects of toxicity even at therapeutic doses. I encourage you to read the Secone pharmacology chapter to see why that happens and additional details. Um, uh, Along with this, these drugs can also cause seizures, and uh, that is another side effect of xanthine derivatives. Typically, xanthine derivatives are used for people who are not responding uh, to drugs such as albuterol, which are used in short-term control, and have landed up in the hospital with significant increase in shortness of breath due to intense long-lasting bronchoconstriction. Another drug that is used for long-term control of asthma-like symptoms are the glucocorticoids. The glucocorticoids are used in any condition that induces an immune mechanism as the basis of the disorder. Since asthma is an immune reaction, uh, therefore, glucocorticoids work very well in controlling the long-term inflammatory reactive airway disease. The drugs of the glucocorticoid variety are beclomethasone, uh, betamethasone, budesonide, methylprednisolone, among others. These drugs are delivered by inhalers or by the oral route. Uh, it is important to understand that these drugs will not relieve bronchoconstriction but rather prevent the immune mechanisms that subserve the initiation of bronchoconstriction. The adverse effects of glucocorticoids are numerous. The fact that we deliver it mostly by the inhaled route prevents some of those complications or adverse effects to occur. However, if the drug does get absorbed systemically, it can lead to all the known side effects, unpleasant side effects of glucocorticoids, as is listed. Because this drug is an immune suppressant, it also um, uh, leads to infection possibility in the areas where it is it is uh, exposed to on the tissues. Therefore, after using of this drug every time, good mouth hygiene should be used or should be performed so that the drug is washed off the surfaces of the mouth and the back of the throat. This will prevent the development of infections on those areas because the immunity is lowered in those areas. The most common infection that does occur in those areas exposed to glucocorticoids are fungal infections. Another category of long-term control drugs in reactive airway disease is cromones. The cromones are particularly or specifically mast cell stabilizers. You will recall from pathology that mast cells are basophils that come out of the blood and fixate themselves in the tissues and contain mediators of inflammation during which are released during episodes of asthma reactive airways. Therefore, it leads to bronchoconstriction if the mast cells break down. The chromone drug will prevent the mast cell from breaking down, and that is why it is called a mast cell stabilizer. The drug is called cromolyn sodium and or sodium chromoglycate. Either way you say it, the drug is the only one on the market which is of this category. It's delivered as a meter dose inhaler via devices such as Spacehalers. The adverse effects are very safe and there is very little side effect of this medication. There are also newer drugs which fall in the category of leukotriene inhibitors. Leukotriene inhibitor drug examples are Zyflo or Xyluton, Montelukast, which is Singulair. You may have seen advertisements of it, and so on. The delivery of these drugs are usually via the inhaled meter dose inhaler route. The adverse effects are few, it's relatively safe. Some reports of liver toxicity has been reported, and these are used usually when the previous group of drugs are not adequate to control the reactive airway disease of asthma. Now, let's look at some of these delivery devices we have been talking about. What are meter dose inhalers and Spacehalers and so on. Inhaled drugs are delivered uh, using either meter dose inhalers or nebulizers. Spacehalers are a category of device that actually facilitates the use of a meter dose inhaler. A meter dose inhaler is shown in the picture below. These inhalers deliver a set dosage per depression, and it is a coordination process. This coordination must be taught to a new user of an inhaler. Unfortunately, a lot of people use the inhalers wrong, and if it is used wrong, it has the tendency to get swallowed more than getting inhaled, and the effect of the drug may be lost. If you recall, any drug that reaches the systemic circulation, before it even reaches the systemic circulation, it will transition through the liver and undergo first pass. Uh, that's why a drug that is swallowed will be subject to first pass. A metered dose inhaler bypasses the first pass effect and delivers a drug topically directly to the lungs. The way it is coordinated is that a patient begins to take, first of all, exhales completely, and then begins to take a breath, and at that moment depresses the inhaler, and then keeps on breathing in until they can't breathe in anymore. They're supposed to hold their breath for a couple of seconds and then slowly breathe out. Usual dosages are 2 depressions per treatment. Meter dose inhalers are also under heavy pressure. So when it is depressed, the drug is released and it hits the back of the throat. The immediate next event would be that the patient swallows. Therefore, majority of the drug may end up going into the stomach instead of the lungs. This is why there is an option to modify the delivery from instead of using it the way the girl in the picture is depicting, but rather to put a spacing device between the mouth um, and the uh, inhaler. So if the inhaler is further away and it is depressed, then the spacing device collects the drug and allows the patient to breathe that drug over a period of time instead of a single breath, and it also decelerates the drug, and allows the patient to get more of that drug into their lungs. And this is what a spacehaler is. It is essentially just a spacing device between the MDI or meter dose inhaler and the mouth. There is a one-way valve, and therefore the patient keeps on breathing in while keeping their lips locked on the device, and the drug which is in that canister, or rather the spacer tube, is inhaled completely. When the person breathes out, they breathe out into the device, but there is a valve that doesn't allow the breath to go back into the tube, but instead dissipates it into the atmosphere. Another mechanism of delivering drugs to the lungs is by use of a nebulizer. A nebulizer is a device which is uh, basically a small cup, and that cup, I'll show you here. That cup is right here. The drug is put here, and then on top there is a baffle that when that baffle sits on top of a jet line. That jet is powered by, you see, a tubing coming from some kind of a compressed air or oxygen tubing. And this compressed air passes through the jet and creates a low pressure above the drug which is in liquid form. When the low pressure is created, the liquid rises up and hits a baffle that splits it into a very fine mist. The person then inhales that mist, and essentially that mist coats the airway and allows the drug to slowly trickle down the airway over a long period of time. This is a good mechanism to prolong the effects of a drug and allow it to be properly breathed in instead of being swallowed by reflex action. Typically, it requires an electrically powered compressed air unit as shown in the second graphic, or it can be a pressurized oxygen cylinder. Either way, you can inhale using a nebulizer using this device on the left, which is called the T-piece. This T-piece essentially allows the person to keep on breathing using their mouth. However, in cases of people who cannot use a TPs because of either cognitive reasons or if there are children involved who cannot do how they are being asked to do, then it can also be delivered using a mask. So either by mouthpiece or by mask. And that is all about this particular presentation. Note the summary slide here, and I will see you again in another presentation. Thank you very much for your time.